Welcome back to PBH 275, Injury Prevention and Control. This is week 10. This week's module will cover the topics of drowning and poisoning. Now, we're only going to talk about poisoning a little bit in this lecture because the largest source of poisonings in the United States is overdoses, which are predominantly driven by the opioid epidemic. And there's a separate film you're going to watch called Understanding the Opioid Epidemic that will cover that a lot. We will start with the topic of drowning, and I'll answer the question of what is drowning. Drowning is a submersion incident that occurs in a liquid. If it's not a liquid, then it would be classified as a suffocation or an engulfment. This happens sometimes in farming, for example, where people will be walking on top of the grain inside a grain bin, and there'll be an air pocket, and they will collapse and fall through the grain. And sometimes people call it drowning as the cause of death, but really it's more like suffocation or engulfment in that case. But what drowning does, and this is from the WHO or World Health Organization definition, is the process of experiencing respiratory impairment from submersion or immersion in a liquid. And there's the difference right there. It's a liquid, and what liquids can do is they can actually get into the lungs, into the deep air exchange regions of the lung, whereas something like grain cannot do that. The WHO further classifies the outcomes of drowning as either death, which is a pretty clear, easy to define outcome, no morbidity. That means that basically the person is able to function just like they were before the drowning incident, or morbidity. And then the WHO further classifies morbidity into several categories such as moderately disabled, severely disabled, vegetative state and coma, where basically there's sort of like a chronic low functioning in the brain and brainstem areas, and finally what's called brain death, which is essentially death because if you're in a state of brain death, you're not going to be able to live without artificial means and artificial respiration. For every fatal child drowning that occurs in the world, approximately 5 children receive emergency department care. When you get to the age of 0 to 4, that number even gets higher. For every 1 death, there are 7 children, 0 to 4, treated in an emergency department. As the WHO definition just reminded us, not all drownings are fatal. You can have a non-fatal drowning incident, which can result in no impairment, some impairment, or significant impairment. The current estimates from the CDC is that about 20% of near drownings, or non-fatal drownings, will suffer permanent neurological damage as a result of the drowning. Usually this is because the brain will get deprived of oxygen until such time as tertiary care can clear the air passages and sort of bring the oxygen back. But during that time of reduced or no oxygen, that's when permanent neurological damage can happen in the central nervous system. A little over 40% of all drowning victims who are treated in the emergency department will require hospitalization or transfer for further care. They might need hyperbaric oxygen, they might need surgery, there's a lot of other things they might need. For all unintentional injuries, the hospitalization rate for those that are treated in the emergency department is closer to 6%. So this gives you an idea of how much more dangerous drownings are even compared to other unintentional injuries. I mean, about 40% of drowning victims who come to the emergency department require more advanced care. The worldwide drowning statistics are pretty stark in their magnitude. The estimate is that in the year 2019, approximately 236,000 people died of drowning across the world, making it the third leading cause of unintentional injury death worldwide. Much of this death was concentrated in low and middle income countries, accounting for approximately 91% of all drowning deaths. If we want to put that number into context, across the world, every hour, 40 people die from drowning. If we look at these familiar CDC graphics once again, showing the leading causes of injury death in the United States in the year 2018. If you look over on the far right column, you won't see drowning there. It's probably just below the 10 leading causes of injury death in the United States as of the beginning of 2019. It's probably either 11th or 12th. But take a look at the dark blue boxes in all the age groups and age categories. You can see that drowning is still a pretty serious injury problem here in the U.S. If you look at ages 1 to 4, it's the number 1 cause of injury death in that category. It's the number 2 cause of injury death in children age 5 to 9, the number 5 cause of injury death in children 10 to 14, the number 6 cause of injury death for those under 1 year of age. And as you can see, once you get past the age of 54, you no longer will see unintentional drowning in the 10 leading causes of injury death. But still, it's a significant burden. And every year, there's about 4,000 people that die in the United States of drowning. That's about 11 people per day. When we look at the drowning statistics in the United States, it should not surprise you to know that there are some disparities in the population. First of all, males make up the overwhelming percentage of drowning deaths, approximately 80% of all drowning deaths in the United States. The higher drowning rate for males there's been several possible factors that have been investigated, and different studies have shown that these are true, but other studies have shown them to be inconclusive. But again, just knowing what we know about public health and about differential risk profiles for people who are born male or identify as male compared to females, some of these possible factors of why males have such a higher rate of drowning deaths would be more exposure to aquatic environments, overestimation of swimming ability. This is something that I did myself when I was a young boy and a child. I assumed that I could make it some distances that it turns out I really couldn't. And thankfully I survived that, but that's a common behavioral factor in a lot of children, particularly males. Just higher degrees of risk-taking, and also higher alcohol use. Children under the age of 14 years have much higher rates of drowning deaths. There's also a socioeconomic and educational attainment status gradient here, where the lower your socioeconomic status or your educational attainment, the more likely it is that you're going to die from drowning. Is there a rural and urban difference? Different studies have looked into this. The consistent trajectory has been that living in rural areas slightly increases your risk of drowning. It's not always been statistically significant, and it's not always been consistently seen across studies. But in general, studies have shown that people in rural areas are at a higher risk than people in urban areas. And a lot of that might just have to do with access to ponds and lakes and watering holes and things like that. Similar to many other injury outcomes that happen here in the United States, drowning has a differential impact based on race and ethnicity. For reasons that I will get into in just a second, Hispanic and Black children are a lot less likely to be taught how to swim and are more likely to report an inability to swim. And inability to swim is a primary risk factor for subsequent drowning incidents. For African American children ages 5 to 14, they have a fatal drowning rate that's almost 3 times greater than that of white children. African American children aged 5 to 19 drown in swimming pools at rates that are 5.5 times higher than white children. And African American children 11 to 12 years of age drown in swimming pools at a rate 10 times higher than white children of the same age. Now, here in the U.S., there's kind of some historical reasons why minority children do not learn how to swim at the same rate as their white counterparts. And they're based on racism and classism and also poor policy choices. In the mid-20th century, when there was a lot of pioneers that were battling to try to improve civil rights in the U.S. and give rights to African Americans that had been denied them, The battleground was not just lunch counters or buses, but also swimming pools and beaches. There were many municipal swimming pools, hotel swimming pools, even beaches that had been off limits to African Americans for decades, and there were some efforts to integrate them, and there was some pushback, and this was actually one of the major frontiers in the civil rights battle. One of the unfortunate consequences of these civil rights battles for integration of pools is that a lot of municipal or city-owned pools didn't really want to deal with protests or strife or anything like that, so they responded to this push to open up and integrate their pools by actually closing their pools to everyone. This actually we wound up with fewer pools for everybody as a result of kind of a cowardly way of, rather than integrating and doing the right thing, of just sort of not wanting there to be trouble, and so therefore closing off something to everyone. And then the next phase of what happened in the 20th century, and it does continue to this day, is that pools have become a lot more privatized now. Since cities don't own pools like they used to, now it's neighborhoods that own pools. There'll be a homeowners association that will have a pool in their neighborhood with like a gate code. And as you would imagine, there have been many cases here in the United States of people being confronted in these neighborhood pools because some of the other people don't think that they belong there based on their race and ethnicity. And so we never really solved the problem in the first place. There was some upstream sort of racist policymaking that was never fully and adequately addressed. And as a result, even in the present day, there are still a lot of minority children that don't know how to swim. And that's a very serious public health problem. So racism and classism, which has led to some poor policy choices, is one of the major risk factors for drowning. Some additional risk factors include aquatic exposure. If you live in a neighborhood with a pool, or if you live close to a beach or a lake, or if you have regular exposure to water, that is a risk factor for drowning. What's a protective factor is having swim lessons. The more confident of a swimmer you are, the less likely it is that you're going to drown. Of course, there is some limitations to that. Sometimes confidence can be a detriment if people overestimate their abilities to swim. But for the most part, swim lessons and confidence in your ability to swim are protective factors. Research from Dr. Jennifer Farr, one of our public health faculty here at UNLV, shows an interesting and inverse relationship between parental fear of drowning and children learning to swim. It was found that as parental fear of drowning went down, that rates of child swimming went up. This has some important implications if you think about it with some of the race and ethnicity factors I talked about before. A lot of African American children grow up in households where their parents have great fear of drowning because they never learned to swim, because pools had maybe been off limits to them for racial and economic reasons, and so therefore they're less likely to learn to swim. Lack of barriers is another risk factor. An isolation fence that goes completely around a pool, like you see up here in the upper picture, that's not exactly a perfect square, so we can call it four-sided if you wish, but basically an isolation fence that separates a pool area from the rest of the yard and the backyard of a house can reduce a child's risk of drowning by 83% compared to when you just have to rely on property line fencing, because that means once you get into the backyard, you have unfettered access to the pool. For children, a major risk factor for drowning is lack of close supervision, because as we'll talk about shortly, especially with very young children, it does not take very long for them to get into a bad situation if a parent or caregiver's attention wavers for even just a moment. Location is another risk factor. Children age 1 to 4 are most likely to drown in home pools or even in home bathtubs, whereas if we're talking about natural water settings, such as lakes, rivers, and oceans, The risk of drowning in those tends to increase with age. Over half of fatal and non-fatal drownings in those aged 15 and older happen in what's called open water, such as Lake Mead, or certainly any bays or estuaries, or the ocean itself. Another major risk factor for drowning is failure to use life jackets or personal flotation devices. The study from Cummings and colleagues, and this has been borne out in subsequent years, the study is from 2011, but this is consistently seen that well over 80%, in the case of the Cummings article, 88% of drowning fatalities were due to when people were boating. It was because people were not wearing a life jacket. The other 12%, some of them were wearing life jackets and they weren't wearing them properly, or they were wearing a life jacket but they had like a high-speed boat crash or something where the fatal injuries were mostly they were still due to drowning, but there were some mitigating factors. So life jackets or personal flotation devices are incredibly effective in keeping a person's head above water while waiting for rescue. For adolescents and teenagers, and then adults, alcohol use is a major risk factor for drowning. The CDC estimates that alcohol is involved in up to 70% of deaths associated with water recreation for those, again, from adolescence through the rest of adulthood. Alcohol is responsible for almost 25% of all emergency department visits that involve drowning, and about 20% of all reported boating deaths. Seizure disorders are another risk factor. People with seizure disorders have to be careful even in water as shallow as a bathtub. And certainly, if you have an uncontrolled seizure disorder, you really need to be careful about swimming in pools or oceans or anywhere else. And as we touched on earlier, parental behaviors and beliefs can be a major risk factor or protective factor. It's shown that children will swim significantly more if their parents encourage them to swim, or if they have members of the family that knew how to swim and swam with them. When parents are not afraid of their children drowning, children will swim significantly more. And when the parent is not afraid of drowning themselves. Again, Dr. Jennifer Farr's research went into this, and this is why there's still such a significant racial and ethnic component to the risk factors for drowning, because a lot of minority children do not grow up in a household where they're encouraged to swim or where their parents enjoy swimming or feel confident in their abilities to do so. Drowning is a quick and silent killer that has a very rapid onset. In the time that it takes to get a towel, which can be as little as 10 seconds, a child can become submerged in water. In the time that it takes to answer a phone call, or about 2 minutes, a child can lose consciousness from being submerged. And the time it takes to answer the front door and maybe talk to somebody about some business or something, about 4 to 6 minutes, a submerged child can sustain permanent brain and central nervous system damage and possibly even die. So again, very rapid onset. It does not take long between taking in water and neurological damage. You do not have to aspirate very much water at all in order to block oxygen uptake and damage tissues. Children can drown in as little as 1 inch or 2.5 centimeters of water. And it's not just pools and bathtubs and toilets. On average, 25 children in the U.S. will drown in just simple buckets. And it's estimated that approximately 78% of infant drowning deaths occur in either bathtubs or buckets. So not a big source of water, but enough to be fatal. There are devices called infant bathtub seats. They have little suction cups on them. They're designed to sort of balance or support a child upright in a bathtub so the parent can kind of bathe them on every side, because, children of that age sometimes need to be bathed and washed on every side because of how dirty they can get. Well, again, the Consumer Product Safety Commission has released warnings on these infant bathtub seats and rings that are used to support an infant in the bathtub because these things can easily become unstuck and tip over, and then the child can wind up under the water very easily. There's been calls to ban these products. They have not been banned yet, but there have been several warnings released about them. What's also seen consistently in research is that parents tend to underestimate the supervision needs of their children, and they tend to overestimate their child's ability to swim. This happens even when there's a parental educational component, and this comes from studies from Morangiello and colleagues back in 2013. Clark County maintains submersion incident statistics that are reported to their registry. Of course, as you would probably guess, these numbers, particularly for the non-fatal submersion incidents, are probably a little bit low because there are probably a lot of non-fatal submersion incidents that never get reported to the registry. Sometimes it's because people aren't even seen in the emergency department for them. So you see the years 2016 to 2019, there were anywhere between 33 and 64 submersion incidents in Clark County that were reported to the registry. Consistently, 70% or more of those involved children between the ages of 0 and 4. Not all of them were in pools. Most of them were in pools, as you can see that if you look at the ratio of number of submersions in pools only versus the numbers reported to the registry. Some of them were in public pools, some of them were in residential pools. The number of fatal drownings among children aged 0 to 4 got as high as 8 in 2017 and as few as 2 in 2019. And again, if we go all the way up to age 14, the numbers go from 4 in 2019 to 10 in 2017. Again, particularly for the non-fatal submersion incidents, this is probably a little bit of an undercount, but as you can see, it is still something that happens here in Clark County, Nevada. In some subsequent slides, I'll get into some specific preventive strategies for drowning, but the most important thing to keep in mind with drowning is that there's a chain of survival. And if you look at this chain of survival, you'll probably notice that the green link in the chain is primary prevention, the yellow links in the middle are secondary prevention, and then the red link on the right is definitely into tertiary prevention at that point, because the drowning incident has occurred. So let's start on the preventive end, on the green end. We want to prevent drownings from happening in the first place. That should be obvious. But then as we get into sort of the, maybe we call it the injury phase if we were doing this on a Haddon matrix, whereas the prevention was in the pre-injury phase. Now we're into the injury phase. Somebody is in distress. People who are in distress in water situations, they tend to struggle, they'll flail, they'll often wave their arms. It's important to recognize these signs of distress, the ones that are actual distress versus, just playing around or something, and be available to contact for help or provide assistance as needed. The next thing in the chain of survival is you want to keep people's heads above water as much as possible, because the longer they're underwater, the more they're going to aspirate water, and the more difficulty they're going to have getting oxygen back to their tissues and their central nervous system later on. So providing a flotation aid as quickly as possible so that even if a person is struggling, they can still at least keep their head above water. That's incredibly important. The next one says remove from water, but only if it is safe to do so. This is something important if you're ever going to do injury prevention, like in a practical sense. Like if you're ever working in a workplace and you're the safety and health person and you've got, say, a confined space in your workplace, or you're over a pool or something like that. A lot of times rescuers wind up putting themselves in danger too, because they jump into an unsafe situation without doing a full assessment first of, do I have the right gear to do this? Do I have the right training to do this? I mean, you don't do people any good if they need help and you jump in to try to help them and you can't help them, and now you're in distress too. Now there's two people in distress. So Part of the chain of survival is getting people out of the situation, but only if it's safe to do so. And then at the very end, it's the tertiary care, providing care as needed and seeking medical attention so that we can get the water out of the lungs as quickly as possible, get reoxygenation occurring as quickly as possible. Because drowning has such a rapid onset, and because so many of the most vulnerable populations for it are very young children, much of the prevention efforts into this goes toward educating caregivers. And some prevention tips for caregivers include the following. Always keep the child within arm's length if there's water anywhere nearby. Put away distractions. If it's bath time, focus entirely on that, because again, it doesn't take very much water or very much time for a child to become endangered around water, even if it's just a bucket of water or a bathtub full of water. If you're using tubs or using things like buckets, containers, and wading pools, empty them immediately after the playtime or the wash time or whatever time it is over. And then make sure they're stored upside down and out of reach. Upside down so that in places where rain occurs more often, if they're outdoors, they don't refill themselves up with water and become a hazard again. There are tragically a lot of young child deaths that occur from drowning inside toilets. So until children are old enough to sort of understand the use of the toilet and the purpose of it and the dangers of it, toilet lids should really be kept closed. And you can even consider toilet seat locks, which are a relatively new invention that can help prevent young children from drowning. It's also a good idea to keep the doors to bathrooms and laundry rooms closed for this very reason. Never leave a child alone in the bathtub. Learn cardiopulmonary resuscitation, which for young children, CPR is quite a bit different than the adult CPR that many of us learn through the American Red Cross. It is also highly recommended by the American Academy of Pediatrics and many other public health and injury prevention professionals that children learn how to swim possibly as young as age 1 to 4. Of course, in saying that, we all have to understand that there are some cultural reasons why some children, particularly minority children, why it be more of a challenge for them to learn to swim, and those barriers need to be addressed, and we need to figure out good ways to overcome those barriers and provide this level of protection to everybody. When the American Academy of Pediatrics reviewed all the evidence and put out their policy statement on prevention of drowning back in 2010, they noted that from one of the case control studies they evaluated in children aged 1 to 4 that drowning victims were less likely than matched controls to have had formal swimming instructions. And that there was like 3% versus 26%. It was also found that participation in formal swimming lessons was associated with an 88% reduction in the risk of drowning in the 1 to 4-year-old children. And again, this is 1 to 4 years old. It used to be a belief that children under age of 4 were not cognitively developed enough yet to even know how to swim. But it turns out that, you can pick up swimming even at a very young age, before you even learn how to walk even. So that data from the American Academy of Pediatrics I just showed you in the previous slide was from 2010. In the year 2019, the American Academy of Pediatrics updated the recommendations, and that's one of the articles that's been assigned to you to read in this week's module. In the new updated recommendations, they said that swim lessons should be considered for all children, including those ages 1 to 4. They didn't come out and completely recommend it, but they said they should be considered. Again, you have to keep sort of the children's level of development in mind. Not all 1-year-olds are ready to learn how to swim. That parents should decide whether to enroll an individual child in swim lessons based on the child's frequency of exposure to water. Again, one of the number one risk factors for drowning. How often are you exposed to water? Emotional maturity. Again, like I said before, not every child age 1 to 4 is going to be ready to learn how to swim. Physical and cognitive limitations and certain health concerns related to swimming pools. There are some children who do not react very well to chlorine or chloramines or some of the other chemicals that are used for disinfectants in swimming pools. And that parents need to understand that swim lessons cannot drown-proof any child, that supervision and barriers remain essential. The Safe Kids campaign here in Clark County, Nevada, publishes what's called the A, B, C, and D's of drowning prevention, the simple rules to stay safe around water. Sometimes we remember things better when we have an acronym, so that's where this came from. The A is adult supervision, the B is barriers, the C is classes, not just swim lessons, but also CPR classes, and the D is devices, personal flotation devices, life jackets, and rescue tools. Again, rescue tools are important because if somebody gets into a distressing situation, they need to be given a rescue tool immediately, such as a floating ring or something, so they can keep their heads above water. Now we will move on from drowning and into poisoning, the other major topic of this week's module. Poisoning is the last of the cause-specific types of injuries that we're going to cover this semester, and there's a reason why I saved it for last, because it is by far the leading cause of injury death in the United States. Nothing else comes even close. Since the year 2016, when poisonings surpassed motor vehicle traffic incidents, since then, it's surpassed it, and the gap has just gotten wider and wider every year. If we look at 2018, this familiar graph again, the leading causes of injury death in the U.S., look at the totals. Unintentional poisonings are up near over 62,000. The gap between it and number 2, unintentional motor vehicle traffic, almost 25,000 deaths difference between the two. So yeah, poisoning is by far the leading cause of injury death in the United States, and so we need to address it. If we want to consider why poisonings are the leading cause of injury death in the United States, it is mostly due to overdoses, which stem both directly and indirectly from the opioid epidemic. I'm not going to cover the opioid element of poisonings too much in this lecture because you have a film that you're going to watch, Understanding the Opioid Epidemic, that's going to cover this in great detail. You also have a discussion board assignment for the Understanding the Opioid Epidemic film that you're going to watch, where I'm going to ask you some specific questions and get your answers from them. So, for the most part, we're not going to cover this a lot in this lecture. Poisonings, in general, are classified as unintentional injury deaths. But with overdose deaths, it's not always possible to determine the intent after somebody has died. We do know that there are a lot of reasons why people unintentionally overdose to death. These include miscalibrating a dose. You got a more potent dose than you meant to get. There's also, when we're talking about street drugs, these can come in variable strengths and purities. A lot of times there will be an unknown second drug in it, such as fentanyl, that people were not prepared for and their body doesn't respond well to, or it can just be an unusually strong batch. Purity and strength can vary, and that sometimes leads to unintentional overdoses. Another very tragic reason why unintentional overdose deaths occur is that when people are addicted and then they try to break their addiction, they go into rehab, they go into some kind of program, and they taper off for a while. Whenever people relapse, a lot of times they will decide to take the same dosage and amount of that thing they were addicted to that they'd taken back when they were doing it all the time. But tolerance gets reduced the longer you go between relapses, and a lot of times that dose that used to be your maintenance dose to get you high can become the dose that now kills you if you've gone a long time with an attempt to rehabilitate in between those doses. There are also people who, frankly, intentionally overdose because they try to use it as a way to die by suicide. But again, we can't always know this intent after a person's died unless they leave a note or have said some things to friends or something like that. So for the most part, overdoses, unless there's some specific instructions or notes or something left behind, are generally classified as unintentional injury deaths. I assigned the editorial from Paolozzi to all of you this week because I wanted to address the question of, are overdoses injuries? Should we consider them to be injuries? A lot of students coming into an injury prevention class are surprised that overdoses are considered injuries by the CDC and by many other public health agencies and professionals. But think about the risk factors and the preventive strategies. A lot of these risk factors and preventive strategies for overdose actually fit well within the traditional injury paradigms, such as the Haddon matrix and the Haddon countermeasures, just like other types of poisonings, which for the most part we've never thought of other types of poisonings, such as childhood medicine poisonings, as anything other than injuries. The past resistance to labeling overdoses as a type of injury that can be dealt with traditional public health injury prevention tools has largely been due to the fact that overdoses are generally self-inflicted, and a lot of times, especially when we're not talking about prescription drugs, when we're talking about street drugs, the overdoses themselves often involve illegal activity, especially when compared to other injury types. There's been a widespread perception that drug overdoses are a social problem, and that the exposure that leads to overdoses might also, depending on your jurisdiction or your value system, might be considered a crime or a sin or even a stigma. But, other injury types also have some elements of self-selected risk. I mean, there are certain types of motor vehicles that have higher risks, like motorcycles, for example. And in public health, our job is to address risks and try to do the best we can to control risks, to create a safer and healthier environment for everybody, even for people who maybe don't choose the safest form of transportation, or for people who are addicted to a substance. We try not to apply a lot of the stigmas and sort of social elements to these problems, because that just kind of clouds it up a little bit. Furthermore, overdoses are like many other injuries in that they have risk factors and vulnerable populations that should be tracked. For example, if a batch of heroin that's got fentanyl laced into it gets into a neighborhood or into a city, that's something that needs to be tracked with traditional public health tools as quickly as possible, because a lot of people can overdose and die very quickly if the medicine that they had been getting before suddenly isn't the same medicine. Now it's got fentanyl or carfentanil or something else very dangerous in it. So again, there are risk factors, there are vulnerable populations that need to be tracked, just like any other type of injury. And public health professionals can share what's been learned, some lessons that can be applied to overdoses from some of the approaches that we've developed to address other types of poisonings. We can talk about the strengths and limitations of behavioral approaches, sort of training children, for example, on how not to ingest harmful chemicals. We can talk about the things that have worked, the things that have not, because some of this can be applied to overdose, people at risk of overdose as well. We can also discuss the strengths and limitations of engineered or agent-modifying approaches. Now, admittedly, this would only be relevant for prescription drugs. For example, the Purdue Pharma, the company that makes OxyContin, has had to think about this a lot. They've done several different engineering things to make the medicine a little bit slower released, a little bit more resistant to the types of illicit use that became such a plague for many years. But of course, no engineered or agent-modifying approach is perfect. And of course, for street drugs that are being that are being sold that are illegal. There's not really such a thing as engineered or agent modifying approaches that are relevant there, but still, we can apply what we've learned from other types of poison prevention to overdose prevention. Like we do with other types of injuries, public health can offer evidence-based and non-judgmental approaches to overdose prevention, which can minimize the injury risk when the primary preventions fail. Yes, we would prefer that people never become addicted to dangerous substances which they can easily overdose on and die. And primary preventions are important, but we have to address the fact that primary preventions won't always work. And if we want to truly help people, truly improve public health, we have to think a little bit farther downstream as well. This is where public health has traditionally advocated for programs that sometimes the rest of society has not really endorsed these ideas. There's been a lot of political resistance, a lot of religious-based resistance, but still, these are things that work. We know that clean needle exchange programs work. They reduce not just the risk of overdoses, but of other types of infections being acquired through injection of drugs. We know that withdrawal management interventions, including medication-assisted therapies, work very well. And these are things that as public health we can provide and bring to this problem. Supervised injection sites. Oh, this one is really controversial, but it's something that some cities and towns in the U.S. have started to do, where sites where people can safely self-medicate. And the big problem with these, of course, being that if people are self-medicating with drugs and substances that are still technically illegal under federal laws, that can be, there can be some jurisdictional problems with that. But we do know that supervised injection sites, they've been tried in places like Philadelphia and San Francisco, and they have greatly reduced the number of overdose deaths that occur. Can also train people, not just people that use these drugs, but also just people in the communities, people who might interact with those who are in overdose crisis, on the use of Narcan or naloxone, these opioid antagonists which can rapidly saturate the binding sites for opioids and actually reverse an overdose after a really quick little intranasal administration of it. These are all some tools that public health can bring to the problem, and that's why we should consider overdoses to be injuries that are amenable to public health solutions, because they are. So that's all that I'm going to say now about overdoses and about the opioid crisis here in the U.S. You have another film that you're going to have to watch and a discussion board assignment to complete about that will provide a lot more information. So let's shift our attention now to preventing poisoning in childhood. Even though there's a lot fewer cases of this than there is of drug-related overdoses, this is still a significant source of poisoning, injury, and death here in the United States. It's estimated that on an average day, approximately 300 children will go to an emergency department due to being poisoned, and 2 of those children will die every single day. There's a few different approaches for childhood poisoning prevention. We can start with education. Caregiver education is very important because, like again, we talked about with drowning, children might not have the cognitive abilities yet to really recognize what's a hazard and what is not, but education can help caregivers understand and create a better and safer environment for children. We don't really have a lot of evidence that children's education on avoiding poisonous substances by itself is effective. And one thing that we've had several decades to look at is you might have heard of the Mr. Yuck campaign. It was introduced back in 1975. Actually, during the Super Bowl back in 1975, there was a 60-second ad that played during one of the ad breaks, introducing this character. You see him there on the green yuck face you see on the right of the slide here. It became a cultural phenomenon. Parents started to request these Mr. Yuck stickers to put on different household cleaners and other products. The idea was that this sticker would sort of warn children that this is not something you want to drink. Even if it looks interesting or attractive or tasty, this is not something you want. As we'll talk about in a second, there's some limitations to that type of education, but it does play an important cultural role, which is what we'll get into next. So, like I said in the previous slide, we don't have a lot of evidence that children specifically change their behaviors around, say, hazardous household chemicals and things like that because of the Mr. Yuck campaign and the Mr. Yuck stickers. What we do know, and this is why education is important. I don't want you to think that I've ever downplayed the importance of education. Yes, there are some upstream things that are probably even more important, some primary prevention strategies, but education can actually change cultural norms, can change the environment, can sort of make people expect more and expect better. And that's exactly what happened with the Mr. Yuck campaign. The awareness raised by it led to improvements in child-resistant packaging and in caregiver education on poison hazards. I mean, the biggest thing that the Mr. Yuck campaign did was that parents and caregivers started to recognize all the products they had in their house that they need to keep out of reach of their children. Not just put a sticker on it to scare the children away, but actually keep them out of reach because they're very dangerous. So, in that way, the educational campaign was very effective on parents and caregivers. This caregiver education created a further demand to create additional products, such as child-resistant locks for cabinets. Many of you probably grew up in households where some of the lower cabinets of, say, your bathrooms had those locks on them where when you were young and didn't quite have the cognitive abilities yet to do the three things necessary to open it, you couldn't get into those drawers. And probably was very frustrating to you as a child. But those products didn't exist in the 70s and 80s. There had to be a demand for those products, and the caregiver education created that demand. Also, the National Poison Control Hotline, it wasn't always posted on every refrigerator and by every telephone, back when people had landline telephones. A big national campaign went into that, and so now it's prominently posted in a lot of homes, a lot of businesses, a lot of daycares, places like that, where if a child gets something in their mouth, a caregiver can quickly call that number and get some professional help about what to do. So here are some childhood poisoning prevention strategies. Again, these are aimed largely at parents and caregivers because they are the ones who, for the most part, create the environment that the children live in and therefore have a lot of control over what types of hazards children might be exposed to. The most important preventive strategy, and this is something that the Mr. Yuck campaign really brought home to a lot of parents and caregivers, is that all medicines and toxic household products must be kept in a place where children cannot get to them. They can be locked, or they can be put well out of reach, or you can do both. And again, you have to keep in mind, like, what level of development is the child that you're watching over. There are some types of locks that once a child reaches a certain age, they might be able to figure out how to defeat them. The same thing with keeping things out of reach. Children can get very creative about reaching things that you wouldn't think they'd be able to reach. So just keeping things out of reach and then periodically doing an assessment of, are the current things I'm doing still good enough based on the level of development of the child? We have child-resistant caps now on things like medicines. That was another valuable thing that happened starting in the 70s. A lot of these child-resistant caps, though, actually have, for people that don't have children, will actually have a second way you can put them on, where it's more like a traditional screw-top cap. It's got like the one side that locks, the other side that does not. If you have small children around, please make sure that child-resistant caps are kept in the child-resistant phase, not in the normal screw-top phase. Read all labels carefully before giving any medicine to children. The dosages might surprise you. They are a lot smaller than us. They don't need nearly as much as a full-grown adult does. With any type of medicine or household product, one of the biggest things to do is elimination. If you don't need it anymore, don't keep it. because if something is kept, it remains a hazard, no matter how high away you put it up or how well locked you keep it. But if it's not there, it's not a hazard. Let's also address something that often happens with slightly older children, particularly adolescents and into the teenage years, and it's really important to have honest and age-appropriate discussions with kids about the dangers of viral challenges that they might see online and might want to imitate. In the past few years, there have been a lot of kids, a lot of adolescents and teenagers who have wound up having to go to the hospital because they consumed a large amount of cinnamon at once. That was a cinnamon challenge. And they wound up with pulmonary edema and some very serious complications as a result of this. There have been many kids who have been sickened by eating Tide Pods. In the case of adolescents and teenagers, it was deliberately eating Tide Pods and filming themselves as part of a challenge. Younger children might look at things like Tide Pods and it looks appealing to them. So it's always important to, and we don't know what the next viral challenge is going to be, but just always have honest and age-appropriate discussions about, how you don't have to do things that you see online. You should, come to somebody you trust and talk to them if you're thinking about doing something like this. These don't happen a lot, but when they do happen, it's a very unique tragedy because there's often a lot of societal judgment that comes with people whose children either get severely injured or die as a result of copying a viral challenge. As we get near the end here, I want to talk about some natural poisoning threats that need to be considered and not forgotten about. There are some plants that are often found in gardens or even indoors that can be poisonous to children if they are ingested. These would include, and there's pictures of them here from left to right, the oleander, which is common here in a lot of southern Nevada landscaping gardens, the calla lily, the tiger lily, the holly. Its big red berries can be particularly attractive to children, but are poisonous if ingested. And also the caladium. There's many different colors of caladium. They tend to have these colorful, veiny leaves like you see here. But these are all poisonous if ingested, so if you're a parent or a caregiver, these are things that you might want to watch and make sure your children are not exposed to. And finally, if you're a parent or a caregiver, or plan to be a parent or a caregiver in the future, there are some outdoor plants that can be poisonous, not from ingestion, but from skin contact. These would include, it's important to train a child if they're in an area where poison ivy, poison oak, or poison sumac exist, about how to recognize them and how to stay away from them. There are a couple of plants, the cow parsnip and the giant hogweed, pictured here. They look a lot like the relatively more benign Queen Anne's lace, but these can sensitize the skin and cause some blistering and some other very negative health outcomes. So you should make sure to keep any children in your charge away from anything that looks like the cow parsnip, the giant hogweed, or Queen Anne's lace. And here in the Southwest, we have another thing called the poodle dog bush. It's that purple bush you see there on the lower right. Again, it's very attractive looking, but you do not want to have any skin contact with this, and children need to be trained and kept away from that. So that's it for this week. Don't forget you have the other film to watch as well about the opioid epidemic. There is both a key summary assignment and a discussion board assignment for this week. Let me know if you have any questions or concerns. Thanks for your attention.